Management of acute exacerbation in a child with asthma. So let us just discuss this with help of a case. Just imagine a case coming to you, 3-year-old male child, and child has come with the complaints of fast breathing and wheezing. So I have taken HOPI. There is 2 days history of cough and running nose. Since morning, there is audible wheeze, breathlessness while playing, and feeding is reduced, but able to drink fluids. Now there is no sudden onset of cough. So I have asked in particular about the choking, about the foreign bodies. So there is no sudden onset of cough, no choking, and there is no fever. Past winter, there were similar episodes. With the nebulization, it was relieved. Again, I have asked about any other congenital heart disease or any ICU stay or any family history. Father has history of allergic rhinitis. Next, on examination, I see the child is alert, able to speak in words or phrases, able to drink well. Respiratory rate is 42, pulse rate is 138, saturation is 94. On respiratory system, there is mild chest retraction and wheeze is audible. So with this, what is your impression? Just keep it in your mind that what will you do next. So first thing is primary entry point. Child presented with cough, wheeze, and respiratory distress is there. So we definitely consider this case of asthma with no fever. Next, I assess the child. So we have already assessed the child. We have seen that there is tachycardia, tachypnea. Saturation is 94% at room end. There is audible wheeze and there is mild retractions. So which category will this come into? Severe or mild and mild to moderate? So this is mild to moderate exacerbation. Next, how you will treat this patient. You have identified this is an exacerbation. Also, there is past history. So how do you treat? What do you do first? You give a bronchodilator. Either you can give MDI or you can give nebulization. Both are safe. If saturation come down, give oxygen. If child is deteriorating, give steroids. Then what do? I have given salbutamol. Then what do? Will I leave the child? No, I will monitor the child, right? For 1 to 2 hours I have monitored. Now I am telling you this is the status. After 20 minutes, respiratory rate has come down to 38. Saturation is the same, 95. Wheeze is persisting, but distress have come down. There is less distress. What do you do next? So here you are seeing that there is some improvement. So this is a partial response. Now again I have given salbutamol and again I am reassessing. Now I am telling you I have given 3 salbutamol doses. Now the respiratory rate is 34, heart rate is 120, saturation is 96. Now everything is improved. Child is playful, he's feeding well. Only mild wheeze is there on auscultation. Apart from that, there is no other symptom. So what is your interpretation? That the child is improving. Then what do you do? Since there is still wheeze persisting, you would like to start salbutamol. So salbutamol inhaler you will give and gradually you will step down. Next, you have to discharge this child. How do you plan for discharge? So before discharge, you have to make sure the child is stable for at least 1 hour of observation with saturation maintained well and parents are confident enough to give a MDI. You have to explain them the danger signs and they have to be trained to give the reliever and bring the child to hospital. So discharge plan, how you will do? So you have to keep these 5 things in your discharge plan. One is reliever, what you are giving, how you are giving. Next is controller. Next thing is inhaler. You have to educate the parents how to use the inhaler properly and when to give it, how much to give. Everything you have to explain and counsel the parents. Then you have to give them a written action plan, like what you have to do, what are the symptoms, then what you have to do. They have to have a clarity that when do I react. So you have to discuss this action plan and explain them. After that, you have to make sure they follow up after 1 to 3 days and gradually you can monitor the patient. Next, at follow-up, I'm giving you the scenario that after 3 days, there is no night symptoms, there is no cough, child is active, playing well, there is no need for inhaler. So this is the case that you have managed successfully. Next visit, if the child is improving or deteriorating, that you have to reassess, right? That is the step down, step up principles in GINA that we will see in the next video. So if the child is 6 to 11 years old, then what we will do? Everything is pretty much same. Only the classification is a bit varied. Here we are telling life-threatening asthma when there is silent chest or child is lethargic or confused. So here we are using the term life-threatening directly, and mild, moderate and severe, right? Mild, moderate, here talking in phrases is the same thing. Not agitated, no respiratory distress. Here heart rate is 100 to 120. Respiratory rate is increased but not more than 30. Saturation is 90 to 95% maintained. If we are doing PEF, it is more than 50% predicted. Severe means what? Severe means if the child is talking in words, he is agitated, respiratory distress is there, then tachycardia is there with more than 120 beats per minute, tachypnea is there more than 30, saturation is falling less than 90%, and if PEF is available and you're doing, it will be less than 50%. Then this is all severe asthma. Here, one more difference is there that when you are giving SABA as a reliever in the less than 5 years age group, here you can use MAT. What is MAT? Maintenance and reliever therapy. It has ICS and formoterol. This combination you can use as an initial reliever and controller also in more than 12 years of age.